Sure. Hi guys, my name is Dr. Lalani. I am an internal medicine and palliative care doctor, and I'll go over what an internal medicine hospitalist and what a palliative care and hospice doctor does. A topic I really wanted to discuss with you guys today is how to deal with a patient's death. No matter what field of medicine you go into, this is something you will all experience, even if you don't just go into, even if you're not just going to become a doctor, even if you're becoming a nurse practitioner, PA. This is something everyone in the medical field experiences. And then we'll also go over a case. So, this is going to be like an actual shadowing session. We'll talk about a case. We'll talk about, how things are. Why is it that we approach this case a certain way? So if you guys have any questions, feel free to ask. So a little bit about me. I am an internal medicine hospitalist. A hospitalist is someone that manages your care when you're admitted into the hospital. So for example, let's say someone comes in with the doctor decides, oh, this patient has to be admitted into the hospital because they have to be worked up for this chest pain. And so I'm the doctor, the hospitalist that manages the patients that are admitted into the hospital. So the patient with chest pain, the emergency room doctor would call me, the hospitalist, and I would admit the patient, and I would follow the patient from the time they're admitted into the hospital to the time they're discharged from the hospital. I also coordinate care with other doctors. So for example, this patient that had chest pain, I would call the cardiology team and I would be the main doctor managing him, but then I would call all these consultants, let's say, the lung doctor or the I did my medical school at Toro College in New York City. I did my residency in Brooklyn, New York, and then I did my fellowship in palliative care and hospice at NYU School of Medicine. I am also a locums doctor. So a locums doctor is someone that travels. So I go to areas all over the country where there's a shortage of doctors. I live in New York City, but I travel from New York City to other places. Most of the times I am working just in New York City at different hospitals in the city. But 1 to 2 weeks out of the month, I travel to areas where there's a shortage of doctors. When I was, in medical school and I was in residency, I wanted to take a few years off to kind of just give back. And initially, I was thinking of traveling internationally, to Africa and all these other countries where there's a shortage of doctors. But when I was doing my research, I realized that there are a lot of, states in United States itself that have a severe shortage of doctors. Even New York, for example, upstate New York has, some very rural areas where not a that doesn't have good access to healthcare. So I travel to these areas. What I work through a company that, flies me out there. I am there for majority time, a week max, and then I fly back. Throughout the pandemic, I have been working in New York City because New York City has been so hard hit with COVID. I've been working at pop-up facilities, which are these hospitals that were erected by the government to kind of help with the surge of cases. So all those tents that you see, I was working in those for months. Currently, I'm working at a hospital in the Bronx, New York, to help with the surge of cases there. As a travel doctor, last month I traveled to Texas to help with the surge of cases there. So it's been really interesting traveling during the pandemic and seeing how COVID has impacted different states and different communities. I'm also a media contributor. I write a lot of articles for Yahoo and Forbes and all these magazines, just educating the public on, whether it is COVID-19 or general medical topics, and then also some podcasts and some news interviews. So now I'm going to discuss a case. I just want to be careful of the time. So I'm going to discuss a case. We're going to go through this case together. This is a very sensitive case. It might be something that's very hard to hear, but I want to discuss what the field of palliative care and hospice does. And it's important to talk about this case openly. So the case we're going to discuss throughout the presentation is Mrs. Smith is a 45-year-old female with stage 4 metastatic breast cancer. She is admitted to the hospital with severe pain in the hip and lower extremities and upper extremities due to bone metastasis. Her disease has progressed and she is now tired and with decreased ambulation. She follows with the oncologist, who is the cancer doctor, regularly and is currently not a candidate for chemotherapy due to prognosis of her disease. So you are consulted as for pain management and goals of care. A little bit of social history. She is married with 3 children. She used to work as a biology teacher in high school, and she is very involved in her church and community. So just to kind of recap, we have a patient that's admitted with stage 4 metastatic breast cancer. The cancer has progressed throughout her body. She's coming in because of severe pain because the cancer has metastasized to her bone. The oncologist, who's the cancer doctor who follows her, says that she's no longer a candidate for chemotherapy and nothing can really be done treatment-wise. And then the palliative care doctor is called in to manage symptoms this patient might be having and initiate goals of care conversation. So what is palliative care? So palliative care is a field of medicine that focuses on anyone with a chronic serious illness. So whether it is dementia or cancer or end-stage heart disease, end-stage lung disease, and our job as a palliative care doctor is to manage any symptoms these patients might be having, whether it is difficulty breathing or pain because of cancer, or tiredness, any symptoms this patients might be having. We are experts in symptom management of chronic illnesses. And then we also provide support to patients' family and friends. So, we're the doctor that's called in to explain things in detail to patients and families about what's going on, talk about their prognosis, kind of break bad news at times to be like, this is what's going on with your disease. Palliative care I work in a multidisciplinary team, so it's not just me. It is, I have a nurse practitioner, nurses, social workers, chaplains, and they're all very big part of our team. Our job is to address, any physical, emotional, and spiritual needs these patients might have. And that's why it's really important for us to work in a team. It's appropriate at any age and at any stage of the illness. So, it's not just for adults, it's also for children. And it can be provided along with curative treatment. What is hospice? So palliative care is for anyone with a chronic illness that needs help with symptom management and goals of care. Hospice, on the other hand, in order to be eligible for hospice, you have to have a prognosis of 6 months or less. So you have to have 6 months or less to live in order to be eligible for hospice. And what is hospice? People always think of hospice as a place someone goes to, but it's actually a service that is provided. So the service is that, the doctor, the nurses, social workers, chaplains visit patients wherever they are. Most of the time it is home. This is at home hospice. This is where, patients decide that, okay, they have 6 months or less to live and they want to die comfortably at home. So the hospice service is provided at patient's home. So the doctor, the nurse, the social worker, everyone visits the patients at home and we manage any symptoms the patients might be having and take over their care. It could also be at a nursing home. It could also be at a hospital. So it's anywhere. So it's not so much a place someone goes to, but it's more of a service. And the goal is to make sure a patient is as comfortable as possible and surrounded by family and friends when that time comes for them to die. Again, I work in an interdisciplinary team approach. So I have a nurse practitioner, social worker, chaplain, therapist, grief counselors, and all of these team members play a very important part in our care for the patients. So the way that palliative care and hospice works is that we work in a team approach, but we have a mind, body, and soul approach. So, my job as a doctor is not just to manage any pain and symptoms this patient might be having, but also provide psychosocial support, provide any religious support. And that's why it's really important that I work with my fellow team members to address all these needs. Because when we look at patients, we always look at patients as a whole, not just, okay, she's here with pain, but what's causing her pain and what's going on, and what about the human part of it. What about the fact that she has 3 children and she's a biology teacher and she's working, and how can we help her in those aspects of our care too, because that's what makes humans humans, right? It's not just her pain, but it's also different aspect of her life that make her who she is. So again, the case, the 45-year-old female with metastatic breast cancer that has progressed to her upper and lower extremities because of the bone mets. Oncology has said that there's no treatment for her. We are consulted for pain management and goals of care. She's married with 3 children, used to work as a biology teacher, very religious, involved in her community and church. So pain management. So the first thing I'm going to do when I walk in to see this patient is manage her pain, right? Because when someone is in a lot of pain, they're not able to tell you anything else. So I want to make sure that I'm getting a very thorough history regarding her pain. So first I would ask her, the mnemonic we use is PQRST. So first I would ask her, where's the pain located? What's the quality of the pain? Is there something that makes it better? Is there something that makes it worse? How long have you had it? Did you already take something at home to make it better? Is there something that makes it worse? Is it worse when you're moving? Can you describe the pain for me? Is it throbbing? Is it, stinging? Is it burning? Is it sharp? And it's really important to get a thorough pain history so I can figure out what type of pain she's having. So there's different types of pain. There's somatic pain, which is pain that occurs when there is when the pain receptors, like the muscle, skeleton, joints, are impacted. Typically, we say somatic pain is a type of pain when someone has like a force trauma or temperature or vibration changes. Usually a somatic type of pain is described as cramping and gnawing. There's nociceptive type of pain, which is a general term used to describe physical damage. So for example, if someone has like a dental procedure, they're having nociceptive type of pain. There's neuropathic pain, which is when there's sensory system is impacted and there's nerve damage. Usually we see this pain in diabetic patients. So, usually patients describe this pain as burning and tingling. So just based on her pain history and how she describes her pain, I can tell, okay, is this somatic pain? Is it neuropathic pain? And different pains are treated differently with different medications. So the way the pain works is like, let's say if you have a cut in your arm, right? And you get a paper cut, there are these sensories and these pain pathways that reach your brain and reach these receptors in your brain that tell your brain like, hey, you're in pain and you're having this type of pain. And the way opioids, and pain medications work is that they target these receptors in the brain that kind of tell your brain that, hey, you're having pain. So they target these receptors that impact the pain and affect these pathways. So in her case, she has somatic nociceptive type of bone pain because, it's metastatic bone pain from the cancer. And I would treat her with opioids. I know opioids get a bad rep, but, opioids such as morphine, Dilaudid, oxycodone, these are all created to help patients that have severe pain, especially like cancer-related pain. And this is what they're created for, to make sure that, people are as comfortable as possible. And so what I would be doing is I would look at her kidney function, I would look at her liver function, and based on, how her kidney function is and liver function is, I would give her different types of opioids based on her labs. And I would also make sure to give her some stool softeners because opioids can cause constipation. Some common side effects are nausea, vomiting, drowsiness. And when we prescribe opioids, we don't ever take it lightly. These are very controlled medications, and we make sure that, we are monitoring them very closely. We're making sure they have a very quick clinic follow-up. We want to make sure that there's no potential for abuse. And then also, depending on the type of pain she has, there are other pain modalities that we use, like radiation therapy, all just depending on the type of pain and where the pain is located. So like I said, palliative care not just looks at like the physical aspect of it. We also look at the psychosocial aspect of things. She has 3 children. She's currently married. We have to make sure that we're providing support to the family and friends. She's a biology teacher. I would make sure to get the social worker on our team involved to see, is there anything that this patient needs help with? Does she need help with, calling her work and making sure they know that she's very sick, admitted to the hospital? Or, making sure that there's enough therapy provided to her children. Maybe she needs help talking to her children about what's going on, because she is diagnosed with metastatic cancer. So that's where the palliative care team comes in to be like, we're going to make sure that we're not just, managing your pain, but we're managing everything as a whole. And then spiritual, like the case said, she is very religious. She's Christian. It's a big part of her life. And so I would involve our palliative care chaplain to make sure that we're addressing her spiritual needs, because denying someone, either the spiritual or social aspect of their care is not giving a whole, 360 level of care. So I would get our palliative care chaplain involved to see, do we need to contact other members of the community or the church she follows with to see if like the priest knows what's going on? Do they need to come visit her? Are there special prayers that need to be held? Whatever it is that we can assist with. So now, we're moving on further in the case. So the oncologist said that she's no longer a candidate for chemotherapy. So she's no longer going to be receiving treatment. So that's one of the things we do is breaking bad news. When we are breaking bad news to patients, we are telling them that, for example, in this case, their disease has progressed or they're no longer a candidate for chemotherapy. And so in this case, I just wanted to kind of walk through with what I do when I have to break bad news to patient. So I use what I call the Spikes protocol. So the way the Spikes protocol works is that S is for setting. So before I even tell the patient the bad news that she's no longer going to be receiving chemotherapy, I set up a setting. So I make sure that we're in a comfortable environment, whether it is in a room or wherever it is, where I'm making sure that the TV is off and, there's enough seating for all the family members so I can comfortably discuss with them what the oncologist is thinking, what we are thinking regarding her care. P is for patient's perception. I would ask her before I give her bad news, what is your understanding of what's going on? What have the doctors told you so far? I is for invitation. I would ask her, is it okay for me to share some information with you regarding your prognosis or care? K is for knowledge. Then I would be like, okay, so, the oncologist, based on how your cancer has progressed, has told me that you're no longer going to be receiving chemotherapy. And then E is for emotions. After I give her the bad news, I would just, make sure that I'm really there for her. Most of the times patients are crying because you just give them such life-changing news and family members are around, and you want to make sure that you're able to be there for them. You're able to really talk to them about what's going on and make sure that they know that we're never going to stop caring for them, even though they're not getting chemotherapy anymore. And then S is for summary. You always want to summarize at the end of it to be like, okay, so what did we just discuss? So I just want to make sure that whatever it is that we wanted to communicate to the patient has been properly communicated. So goals of care. So goals of care conversation is when we talk to the patient about what they would want going forward. So now we have told them that she's no longer a candidate for chemotherapy. What are her goals and wishes? So now that she is not going to be getting chemotherapy and her cancer has progressed, does she want CPR or does she want to go naturally if her heart ever stopped? Does she want to be intubated when you're put on a breathing machine? If so, how long? Would you be able to be someone that is in a vegetative state, or if that's something you would never want for yourself? It's really important that they communicate these things with the family and let them know what their wishes are. And then in this case, the patient decided to be DNR DNI, which means that if her heart ever stopped, she would want to go naturally. So now we're going to switch gears and we're going to talk about how to deal with the patient's death. So you are the resident on call and you are notified that Mrs. Smith has died at 2 a.m. So you are called to pronounce her and do a death exam. So prior to doing a death exam is, you want to make sure you're checking the patient's resuscitation status. So in her case, she's DNR DNI, so she does not want CPR. You also want to make sure that you're reviewing the patient's note before you go see her. You want to know a little bit of background about her, especially if you're not taking care of her. You want to know circumstances that are surrounding her deaths that are documented in the chart. If there's any family or friends around, you want to make sure you're introducing yourself and offering your condolences. And then the death exam itself is something you'll learn like in residency. You want to make sure you're appropriately gowned, especially during COVID times. You want to confirm the patient's identity. You walk into the patient's room and you assess them for any movements, any respiratory effort. You call out their name to make sure that, hey, can you hear me? You assess their pupillary reflex, which is the reflex in your eye. After that, the pupils become really fixed and dilated. You want to check their carotid arteries and their radial arteries to make sure that there is no arterial movement. You want to get a strip, an EKG strip that shows some flat line, knowing that there's no rhythm or activities in the heart. And then you ungown. Sometimes in the ICU, if they're brain dead, we do apnea tests. So there's just a lot that we do. So, this is pretty tough to talk about these things. Obviously, it's not easy to talk about, doing a death exam and a patient's death. So death is a normal part of life, but that doesn't make it any easier. Seeing a patient die is something all medical students, residents, nurses, physicians, and all other medical providers will experience in their career, no matter what field of medicine you go into. Obviously, if you are more on the outpatient side and you're choosing a specialty that doesn't really, take care of very sick patients, then that's different. You're not going to be seeing a lot of patients die. But especially if you're someone that's doing emergency medicine or, internal medicine on the inpatient side, like hospitalists, you are more likely to see a lot of people die. I mean, during COVID, that's definitely been one of the toughest things. All of us providers have just seen so many people die, and that's been the hardest part. So you want to make sure you're expressing emotions. You just saw a human being die. That's not easy. You want to make sure that you are able to discuss your feelings, especially if you got close to the patients. There are going to be some patients you're going to be caring for a very long time and develop bonds. So you want to make sure that you're letting yourself feel the loss, and express your feelings openly to your colleagues. When you'll be in medical school or residency, you're going to get very close to your coworkers because you'll be working so closely with them. And so you want to make sure that you're able to communicate with them like, hey, I got really close to this patient. I was following them for a very long time. I'm really sad they have died. And, just really kind of express your emotions openly. Take some time to reflect. Everyone deals with patients' loss in their own way. Take time to reflect on what you just saw. It's not easy. You also, one of the book recommendations I always make is Ethel Gawande's Being Mortal. It's important when you are thinking about a career in medicine, you're not just reading biology and organic chemistry textbooks, you're also reading books that really kind of teach you the human side of medicine, which is a big part of what we do. Dispel any feelings of failure. If a patient dies, it has nothing to do with you. You can't control if someone gets metastatic cancer or any other chronic illness. It's not up to you. All you have to do is do your best to treat the patient. And if things get harder, speak to a licensed therapist. If you start feeling like you're not eating, you're not sleeping, it's impacting care that you're giving to other patients, then it's important that you realize that this has really impacted you in a very negative way, and it's important to ask for help. Because if you're not able to take care of yourself, then you're not going to be able to take care of other patients that you see. So that was a tough topic. I know this wasn't easy, but I really commend all of you guys for sticking through it. I'm just going to switch gears into some advice for medical school, and then I'll take any questions you guys have. I see the chat. So one of the advice I give always for medical school is to have a mentor and shadow doctors. Obviously, it's been very tough shadowing doctors right now with COVID. You know, I'm not allowed to take any students because I want to make sure that, you know, you guys are all very safe. Where no one is really allowed to take any students right now, just for safety reasons. But you know, doing these sessions, these virtual shadowing session is a great way to, you know, get exposed to different fields of medicine and see what the whole field of medicine is truly about. You know, it's important to keep an open mind, you know, keep an open mind going into medical school. When you're in medical school, you will go through different rotations. And during those rotations, you'll figure out what you like, what you dislike. You'll do a rotation in medicine. You'll do a rotation in internal medicine. When you're shadowing a hospitalist, you'll do a rotation with surgery. You'll do different rotations, and then you'll just kind of decide what you want to do based on that. Make sure you volunteer. You know, all of us going to medicine to help people. You want to let people know that, you know, you want to help people as well for free and don't get paid to do it. So it's really important to do a lot of volunteer opportunities as much as possible. Study early, apply early. When you're applying to medical school, you want to make sure that, you know, your applications are in on time. You don't want to be someone that applies last minute. You always want to make sure that, you know, all the recommendation letters and everything that are uploaded way before the submission date. And, you know, when the day comes to submit, you're prepared with everything from your personal statements to your rec letters to everything. And then study, and then extracurricular activities, you know, get involved in a lot of extracurricular activities. I think medical schools like to see people that are well-rounded. They don't just want to see people that are just doing medicine. Honestly, just do things you love and do activities that you love, and just kind of let yourself shine through it, you know. And then most importantly, be humble, be kind. You know, patients like to see doctors that are just overall good human beings, you know, and that truly care for patients, and it comes through. Just be a nice person, and always be kind to your patients. You know, they are relying on you for so much, and you're kind of in charge of their life. So you want to be that doctor that's always really nice and kind and not very mean. So now I'm going to take questions. If I take questions, obviously I only have like 9 minutes left, but you know, feel free to reach out to me through my Instagram. It's dr.lalani, so dr.lalani. If you have any further questions, if I'm not able to answer it, I'll put it in the chat. So if I'm not able to answer like majority of these questions, feel free to reach out to me on Instagram. I try my best. It's obviously very hard because I get a lot of messages and work is very busy. So I'll try my best. Okay, so what questions do you guys have? Fell through a tree once. That's cool. I hit a car once. Very nice. Is there any connection between palliative care and cancer rehab? So, you know, it's possible that we recommend cancer rehab, but most of the times it's not very connected. How soon after the spike conversation is the goal of self-care conversations? So most of the times they're actually together. So when I am breaking bad news, I am also telling them at the same time, like, what are going to be your goals? What are going to be your wishes? And so most of the times they're held together. You know, once I'm starting the conversation, I usually try to do everything at once. How old do you have to be to typically shadow doctors? I'm not sure, because I remember being in high school and just volunteering at the ER and being able to shadow doctors. But I think things have just changed so much with regulations and COVID. So I'm not really sure. What are some things to study? So what are some things to study? So when you hit college, you're going to be doing the general pre-med courses that are required to get into medical school. So for example, I was a psychology major and I did psychology pre-med. So I did all the classes that are required for psychology and then all the pre-med classes like the biologies, the organic chemistries, everything that's needed. So all the material that you need to do is already kind of incorporated in the pre-med classes. What was your answer? Why do you want to go into medicine? Question. So why did I want to go into medical school? I don't know what I wrote in my personal statement, but I feel like in general, everyone goes into it to truly help people. I know during my interviews, I remember saying that I absolutely loved science. Like growing up, it was my favorite subject and I like helping people. So I feel like medicine kind of combines the passion for both. You're able to practice medicine and science and also help people at the same time. And I loved working with other people and it kind of just all fell in. But you kind of have to, to make your own twist on that same topic. Any like specific medicine related questions? I'm like a minute left. What book recommendations do you have for high school students? If you're enjoying your general biology and chemistry classes in high school, then I think that's pretty good enough. Being Mortal is a good book. I mean, it's obviously very high level because it talks about very deep topics, but I think just enjoying your general science classes in high school is really important. Okay, well, that was hope that was helpful. I know this was a tough topic. Reach out to me through IG if you guys have any questions. Where's the host?
Hi. Yeah,
Yes.
thank you for taking the time to come speak to us and organizing the presentation and everything. I know you mentioned, like, when we were communicating through Instagram, that you are a travel doctor and you're really busy. So, yeah, thank you for
Yes.
taking the time to talk to us.
No problem. Have a great day, guys. It was a pleasure. Take
Yeah.
care.
Bye.
Bye.
Bye. Thank you.
Bye.
Bye. Thank